Good afternoon. A warm welcome to all of you in our local community and beyond, and thank you for participating in this event. I'm John August, and I have recently finished my appointment as Interim Dean of the School of Public Health at Texas A&M University. I'm a veterinarian, and I will be your host for this first of the series of COVID-19 conversations. The coronavirus pandemic has negatively affected every aspect of our personal and professional lives. A return to a more normal society will require close collaboration between public health professionals, healthcare providers, politicians, economists, social scientists, and many others, including each of us as responsible citizens. The present global disease outbreak reminds us of the importance of the close relationship between human beings, animals, and the environment in fostering the emergence of new infectious diseases, a concept known as One Health. The School of Public Health at Texas A&M University is committed to transforming human health and well-being through interdisciplinary inquiry, innovative solutions, and the development of future leaders using the Aggie tradition of selfless service to engage diverse communities around the world. COVID-19 conversations will provide a platform for the experts from our school to offer insights into the lives and work of public health professionals during an active pandemic. Before the present health crisis, few people in the general public understood what the term public health really meant and how professionals in the field contribute to our individual health and the health of communities, whether they be local or global. Our program begins by featuring two of our faculty members, Dr. Marcia Ori and Dr. Angela Clendenin, both of whom have been very active in providing expertise to task forces addressing the pandemic in Texas. Dr. Angela Clendenin will discuss the concept of contact tracing, a term new to many of us. Dr. Clendenin's expertise is focused on epidemiology and disaster response. She is an active participant on the Brazos County Health District COVID-19 Task Force and conducts contact tracing locally.
Hi, I'm Dr. Angela Clendenin with the Department of Epidemiology and Biostatistics at the Texas A&M School of Public Health. And today I'm here to talk to you as part of COVID Conversations about contact tracing. That's a question on many people's mind. What is contact tracing? It's something that we're hearing about in the news. It's something that we're hearing is a really important strategy in managing the COVID-19 outbreak. But exactly what is it and how does it work? Well, it begins when a person who may be feeling bad goes in to see a provider and is tested for COVID-19. And when the test comes back, then they are positive, and then they are called a case. The provider, because COVID-19 is a reportable disease due to its high level of transmissibility, is required to report this case to the local health authority or regional health authority or up to the state health department. That case is then interviewed by a public health practitioner. So the interview will collect a lot of information about the case, such as the symptoms they experienced and the date of onset of those symptoms. And this is really important because everybody has been showing different symptoms and not all the symptoms at one time. So this really gives us an understanding of how the disease affects people differently. And then we're going to be asking about their travel history in the prior 14 days, if they have been around somebody that they know or suspect may have been diagnosed with COVID-19. And then we're going to ask them about who they have been in contact with over the previous 14 days. In addition, we're going to ask them if they were ever hospitalized, and if they were they in the ICU? And sometimes based on the timing of testing to reporting to the actual interview with the case, the person may be in the ICU and we end up having to talk to family members to try and reconstruct the contact history of the initial case. And one of the questions we ask before we conclude the interview is, have you notified these contacts about your COVID-19 positive status? It's really important that when someone is diagnosed with COVID-19, that they let everybody know who they've been in contact with that they are positive. Because the people they've been around in the 14 days prior to their positive test may have actually been exposed and may become a case. So when we ask a case about their contacts, we're taking down the name and we take down the phone number, address, and if the case has it, their date of birth, what is the relationship between the contact and the case? And when you're talking about that exposure potential, what was the nature of the exposure? Do they live in the same household as the case? Or are they a family member who is responsible for taking them to the grocery store or to get medical care? Or are they a part of that larger family that maybe had a big gathering over a weekend? Because if it's just a casual contact, an in-passing sort of contact, they're probably not as high a risk for contracting COVID-19. But if they are somebody who has been in close physical contact with a case for a period of a few hours, then their risk level increases, and it's important for them to understand that. So what does a public health practitioner do once they have the contact list? Well, they will actually reach out and call the contacts. They'll make sure they were told about their potential exposure to COVID-19, and then they will ask, have you had any symptoms? Are you showing any signs of illness? And then they will ask them to go ahead and get tested. And that's what's really important, because you can have a case that may have 2 contacts or may have 12 or 15 contacts. And then we need to get them tested because some of them will end up being positive because of their exposure to the initial case, and then they will become a case, and then we have to build on their contacts. So it becomes very much like a web, like a net over a community where we are trying to, wherever the little lines on a net come together, that may be a case or a contact. And we're trying to identify just exactly how far the disease has spread in our community so that we know what appropriate mitigation strategies we need to put in place to contain the disease and eventually slow the spread of COVID-19 in our communities. What contact tracing is not is a way of identifying people who maybe haven't been following the social distancing rules. We're not trying to find people who haven't been compliant and report them. This is not an effort to identify people who may be in our country as undocumented citizens and therefore are trying to get them deported. That is also not the case. We are not trying to collect people's cell phone data or mobility data or health status data for any other use other than to try and track COVID-19 from case to contact, from case to contact, contact to case to contact, because that is the only way that we will be able to get ahead of the curve for this particular disease and try to contain it before it runs rampant through our communities.
Dr. Mari Cote is a member of the Texas A&M University Emergency Management Advisory Group with experience in instruction and research in health policy and management. Dr. Cote will be addressing the many myths associated with COVID-19 and flattening the curve.
Howdy! I'm here to discuss the COVID-19 models that have become a very prominent feature in how we are addressing this complex and evolving global pandemic. Johns Hopkins University, the Imperial College London, and the Institute of Health Metrics and Evaluation, IHME, at the University of Washington are but a few sources where we can find models intended to support our government officials, public health officials, and medical professionals. These models also educate the public about the possible outcomes from this pandemic. Effective models help us recognize how science and human behavior interact and can contribute to how we eventually resolve this pandemic. By way of background, the first confirmed case of local transmission of COVID-19 occurred in the United States in January. A public health emergency was declared on January 31st, and a national emergency was declared on March 13th. These were the beginning of unusual times for us, as most of us have never experienced a pandemic in our lifetime. The challenge for our officials and professionals was to quickly understand how COVID-19 might spread across the United States. To help them, they turned to a well-known public health tool, the infectious disease model. Now, models are representations of reality, such as our current pandemic. They are based upon information contained in the recorded observations of the number of confirmed cases of COVID-19, where these cases are located geographically, including by state, county, city, or zip code, and case demographics, such as age, gender, and ethnicity of the infected individuals. With the latter, we have learned that older people and or those with underlying health conditions can have higher rates of hospitalization and mortality from COVID-19. The models allow us to examine the current pandemic, formulate it mathematically, that is, number-based, with particular assumptions. So, for example, how long might someone be infectious with COVID-19? How many people might be infected or die? And structures, that is, how the model is put together. Once a model is built, it can then be used to consider the effect of policy choices in human behavior. We've seen many examples of COVID-19 models, with their results commonly reported as projections or scenarios on the number of infected individuals, the number of fatalities, possible future dates for the maximum number of infected individuals, and so on. While all the models generally pointed in the same direction, they did not necessarily agree on specific values or dates. This is not surprising, as there are many ways by which models can be built, used, and interpreted. Think about what we see when there is a hurricane in the Gulf of Mexico, and we want to know when and where it will make landfall. What we look for is general agreement. Right now, since COVID-19 is still with us, there remains many uncertainties and many unknowns. Regardless, model results provide guidance on what might be appropriate intervention. This comes from how we use a model's results and conclusions. Early in the pandemic, many officials were stressing the need to flatten the curve, with staying at home and quarantine typically being offered as options. By trying to affect the rate of infection, fewer people would be infected early on and not overwhelm our healthcare resources such as personal protective equipment like N95 masks, hospital beds, including those in intensive care units, and ventilators. What we've seen so far is that the recommended actions, such as stay-at-home orders, have indeed affected the rate of infection. Central to COVID-19 is an infectious disease model called SEIR: susceptible, exposed, infectious, and recovered. Think of the four categories as compartments, or buckets, if you will. And this model determines how many individuals at a given point in time will be in each of the four compartments or buckets. Susceptible to the infectious disease, the first compartment; have been exposed to the infectious disease, the second compartment; are infectious and can share the disease with others, the third compartment; and lastly, have recovered from the disease, the final compartment. Elements of this model can be found in daily news briefings from public health officials, where the number of confirmed cases, that is, the infectious compartment, and the number of recovered cases, notably the recovered compartment, are presented. Importantly, this model, like all models, is highly dependent upon the data collected by public health officials and medical professionals. What we've realized is that it is important to know the time between infection and symptoms, how long it takes for others to get infected, the percentage of infections that are detected, and how long it takes to recover from COVID-19. In turn, this model, like all models in general, is improved over time as we learn more about COVID-19 and how it affects individuals and communities. In sum, models are essential to help us understand the pandemic and to consider what we might do to address the pandemic's effect on our community's health and economy.
Dr. Rebecca Fisher, a faculty member in our Department of Epidemiology and Biostatistics, will introduce us to a day in the life of an epidemiologist. With her background in infectious diseases, Dr. Fisher has been featured prominently in the media recently to provide information and expert opinion to the public.
I'm Dr. Rebecca Fisher, and I'm an epidemiologist and assistant professor at the Texas A&M University School of Public Health in the Department of Epidemiology and Biostatistics. I'm going to talk to you a little bit today about epidemiology and what a career in epidemiology might look like, in particular share some details from my own career and my own experience. My training is actually a little bit more specific than the average epidemiologist because I have more in-depth training in infectious diseases. So infectious diseases are those that are caused by pathogens, such as bacteria, viruses, parasites, and funguses. It's also one of the oldest forms of epidemiology. As you can imagine, we have a long history of plagues and epidemics, and for a long time, even though we didn't understand what causes of infectious diseases were, there's a lot of historical accounts and artwork that document these through history. So something that is different about studying infectious diseases versus other forms of epidemiology as well is that we have to talk about disease spread. So disease transmission, or how that communicates through a community. So there's some mechanism by which they move around from person to person or through a community, such as transmission through food, like food poisoning, through coughing and sneezing, like the flu, through blood, like hepatitis, through animals, like rabies, and through insects, such as malaria or West Nile disease, just to give some examples. So we don't just think about disease in people, but we also have to think about disease in the environment, such as soil, water, air, or in animals or insects, just to give some examples. And then all the same demographic, geographic, and temporal and other environmental factors that relate to disease in those avenues as well. So not just in the person, but in the environment and reservoirs and vectors. So just to sidetrack a little bit and talk about the COVID experience, this is a disease that we saw was first described as an unusual type of illness. It was a pneumonia, which is nothing too unusual, but there was an unusual pattern. So doctors observed a new pattern of respiratory disease, and we knew that the cases of the new kind of disease that wasn't quite what they were used to seeing was clustered together geographically and temporally. So first noticed in Wuhan, China, during December of 2019. So this information would have quickly caused epidemiologists to perk up their ears and immediately try to learn about who was becoming sick, what the cause of disease was, and where it came from. So we use descriptive tools to talk about who, when, where of a disease, and in particular during an outbreak if you're an infectious disease epidemiologist. So one of the most important roles in infectious disease epidemiology is to monitor diseases. So monitoring them using these descriptive tools, and we call this surveillance. So we have some idea of what patterns look like for a lot of diseases. We watch them to see if we see any unexpected patterns. So an unexpected pattern would be like an outbreak when a restaurant serves contaminated or spoiled food, and then a group of people get sick, and then the health department steps in to investigate what it was that made them sick, and even actually verify if it was the restaurant versus some other source. We also do this with diseases that we routinely control through vaccinations, such as when vaccination rates are low and then we see an outbreak, and it drives us to understand how to do a public health intervention with our partners in health promotion and community health to reach those individuals that could be protected. So in addition to those diseases that we sort of know a lot about, we also monitor for emerging diseases. So this includes infectious diseases that might usually be rare, such as Zika, but then suddenly show up in a population that hasn't been affected before. And then also other diseases that emerge, such as animal diseases that we're used to seeing in animals, but all of a sudden we see them causing something in humans that, and that is an alert to us that something has changed. So think about things like avian influenza or Ebola or even COVID, where we see them as a disease a lot in animals, or more so than in humans, but then when we see something that is causing human disease, again, it causes us to perk up our ears and drives us to do an investigation. So with COVID-19, it took scientists, including epidemiologists, working together to determine that a new variety of coronavirus was the culprit. So an example of an old virus in the world that was causing a new kind of disease. So a disease in humans and a new kind of pneumonia disease that coronaviruses weren't really known for. So springing into action, epidemiologists worked really hard to find clusters of this new disease and the sources, such as identifying a large seafood market as a place where a lot of cases had been. So to understand how the virus was actually infecting people. So respiratory diseases tend to be mostly inhaled. So that would help epidemiologists identify some ways to prevent disease. So finding the most efficient means to contain spread, closing down what might be a common source of exposure or a common area where sick people might interact with unsick people so that there would be a high risk of exposure. For example, closing down the seafood market. We might also ask people to remain in place to avoid travel so that it's not spread to new geography. And then also educating people about how to keep from passing the virus between infected and uninfected people, and also some messaging to help people understand what to do if they think they're sick. So this is all a classic example of an outbreak investigation and response. So one of the most important frontline applications of infectious disease epidemiology, and actually surveillance and outbreak investigations are ongoing activities at health departments all the time. So this would be a major job function of a local epidemiologist. So the ultimate goal of investigating disease events and outbreaks is to control them so more people can't become sick.
Dr. Marcia Ori, Regents Professor and the Director of our Center of Population Health and Aging, will discuss the many direct and indirect impacts of COVID-19 on the health and lives of older adults in the community.
Thank you for that introduction. Being the director of our Population Health and Aging Center, I've been thinking about how COVID-19 impacts older adults and what is the best response for helping older adults and their caregivers cope. The COVID-19 outbreak is scary for all Americans, but particularly so for older adults. The cover slide reflects the different images that can come to mind. What we know so far, and we're still learning a lot about COVID-19, is that while younger adults are more likely to get COVID-19, it's older adults, those 65 and older, who are the ones who will have the most serious complications, and they'll be the most likely to be hospitalized and have higher mortality rates. You've all probably heard about the tragedy occurring in nursing homes and other communal living arrangements around the country. It's not age per se that puts older people at risk, but the many comorbidities that accompany old age, like heart disease, diabetes, and respiratory problems. It's important to recognize the great variability among the older population. Some seniors will have health profiles resembling healthy younger adults. Others, especially the oldest old, will have a multitude of health problems that put them at increased risk for serious complications. May is Older Americans Month. The theme is Make Your Mark, celebrating the important roles older adults play in their community. So when thinking about the impact of COVID-19 on older adults, also think positively about what older adults bring to their communities. So what does this mean for seniors and their caregivers as the state opens back up? It's especially important to follow the recommended public health guidelines about hand washing, wearing face masks in public, maintaining physical distance to reduce the risk of being infected and passing the disease on to others. It's important to avoid exposure, but also important to be aware of COVID-19 symptoms and early warning signs of more serious complications. The CDC is a good resource for this type of information. It's important to be vigilant, but also don't go overboard. Be realistic about the risk. Be knowledgeable about factors related to the spread. Try to avoid being tuned in to the news 24/7. This may only make you anxious or depressed. But instead, go to trusted sources for accurate and reliable news. If you are a healthy senior who is staying at home, Think of what you can do to help others. For example, being part of a calling chain to check up on others. If you've already had serious medical conditions or disabilities and you're under home health care, be planful. This means plan what you'll do if your direct support provider gets sick. Plan at least 2 ways of communicating in an emergency situation. Stock up on prescribed medications. The recommended practices restricting physical social interactions with seniors is likely to continue even as the rest of society opens back up. This is to protect seniors from being infected by younger adults who may inadvertently spread the disease. Yet this advice has been especially hard for seniors, and it can increase the feelings of isolation and loneliness. Seniors and their caregivers need to be creative about ways to stay in touch virtually. Physical distancing doesn't have to mean social isolation. Pick up the phone, do drive-by visits, or get on social media to create intergenerational chats or virtual family dinners and other celebrations. But if you've never been on social media platforms, they can be a bit intimidating. Aging organizations have developed resource pages on how to use such technology successfully. The National Council on Aging is a good resource. One positive outcome of the COVID pandemic is that seniors are getting savvier about social media and narrowing the digital divide. As a caregiver, offer to run errands, such as going to the grocery store or pharmacy, but engage in public health best practices in dropping off the items. Encourage your older loved one to maintain normal routines, interspersed with pleasurable events. For example, waking up at a reasonable hour, getting dressed and getting out of bed, eating properly and being physically active throughout the day, sharing stories about family life, and engaging in enjoyable hobbies like gardening or baking. Some thoughts about interacting with the healthcare system. Physical distancing, mask wearing, limited touching may all negatively impact the older patient-provider interaction, especially if this person has hearing or vision problems. Problems are likely to be compounded with those who have severe memory problems, and healthcare staff need to be especially sensitive that new routines are not distressing these populations. If your loved one is in a nursing home or assisted care facility or does get hospitalized, talk to social service providers or healthcare professionals about how you can stay in touch virtually. Most healthcare professionals are doing their best under trying circumstances, but it's important for family members and friends to stay in touch. This is important for the health and the well-being of your older loved one, but it's also to ensure accountability of care. Some long-term facilities are actually passing out iPads for this purpose. And finally, don't be embarrassed to reach out for help. Your local area agency on aging can help connect vulnerable seniors to resources to meet the basic needs around healthcare, financial assistance, nutrition, and transportation. If you are distressed, there are remote distress hotlines. SAMHSA has a particularly relevant disaster distress helpline that offers 24/7, 365 days a year crisis counseling and support. If you're an older worker and you lose your job, it may be harder to re-enter the workforce. The Senior Community Service Employment Program is a valuable lifeline in getting back to employment. Thank you very much for this opportunity to talk about the impact of COVID-19 on older adults and what can be done to help cope during this very difficult time. Thank you again.
Our final presenter will be Dr. Tiffany Radcliffe, Associate Dean for Research and a member of the Texas A&M University Emergency Management Advisory Group. From her background as a health economist, Dr. Radcliffe will be looking to the future as COVID-19 integrates into society.
Howdy. In the spirit of full disclosure, I'm not a fortune teller, so I'm not going to try to predict exactly what happens next. Instead, my goal in this brief conversation is to explain some of the different outlooks that infectious disease experts, modelers, and economists are predicting over the next year or so, and why they are making these predictions. First, what should we expect in terms of future waves of cases, outbreaks, and fatalities in the US and around the world? Many models have been developed to predict when the peak number of cases and deaths might happen, and these models are adjusted as more becomes known about the virus, behaviors, and how it is spread. There are several scenarios for how things will play out that are considered more likely than others. A group of scientists at the University of Minnesota, for example, describes 3 scenarios. The first scenario shows multiple waves of the pandemic that are fairly similar in size to the one we are currently experiencing in spring 2020. These waves will happen for a long time into the future. This scenario means that when COVID-19 cases increase substantially, people will start to become more cautious, emergency orders could be issued again, eventually cases decline, and then there is an ebb for a while. This cycle or wave repeats until most of the population has been exposed to COVID-19 and we establish what is known as herd immunity. These waves would also become smaller when there is an effective vaccine available to prevent or reduce the virus. A second scenario is one where we might see a decrease in cases over the summer and then a much larger wave in the fall and winter. Experts are predicting this scenario for a very good reason. It matches the pattern from several other pandemics, including the 1918 Spanish flu. An interesting reason why this would happen in the late fall or winter is that the environment for other viruses like seasonal influenza tends to be more favorable in colder weather. However, this seasonal increase is still not quite established, nor is it guaranteed for COVID-19. The third scenario is where once this initial wave subsides, tiny waves or clusters of outbreaks will continue to occur from time to time. They call this Groundhog Day, like the movie, or Whack-A-Mole, like the carnival game, because the limited outbreaks occur, are quickly addressed, and then occur again elsewhere. This scenario requires good contact tracing and surveillance testing methods to ensure that outbreaks are quickly identified and contained. Regardless of which scenario occurs, or even if it is some combination of these, most experts agree that once the current wave of the pandemic ends, we can expect at least another year or 2 of COVID-19 outbreaks and hotspots in a variety of geographic areas. A second question about the future is how can physical distancing, stay-at-home orders, wearing masks, and hand washing affect what we might expect to happen? All of these ideas relate to how people can reduce the transmission of COVID-19 and make the wave smaller, meaning that there could be fewer and less severe outbreaks if we change our behaviors to make these our new habits in the future. In other words, whether we find ourselves in scenario 1, 2, or 3 could be affected by how much we stick with these new habits. Mutations of the virus are another area that can affect the future. A small change in the virus can make it more or less dangerous to humans. During this initial wave of the pandemic, there have already been several variations of the virus identified. All of them seem to be most dangerous to older adults and people with specific pre-existing health concerns. But keep in mind that this is called a novel coronavirus because it is the first time we have seen it transmitted to humans. A future COVID-19 conversation will discuss this in more detail. In terms of healthcare resources, hospitals, intensive care units, and providers are less likely to be overwhelmed in the future as scientists continue to work on new vaccines, therapies, and other treatment modalities to help clinicians safely support the medical needs of patients with severe symptoms. This is good news, since that type of innovation will make opening the economy and finding a new normal for our daily lives much easier. However, in the near term, everyone can help by knowing how to recognize the most common signs and symptoms of the virus and use good judgment when social distancing rules are less clear. The immediate economic outlook includes a lot of uncertainty due to COVID-19, as many businesses faced sudden challenges when stay-at-home orders were issued. Businesses had to either temporarily close, cut back dramatically, or completely change their way of delivering services. Thankfully, very few areas of the US had healthcare systems that were overwhelmed. There were some healthcare resources that remain in short supply, and it will take some time for those to catch up to new demands. That includes supplies like N95 masks that are used to protect workers and ventilators for very sick patients. However, most resources that were being reserved to support COVID-19 patients are quickly being restored, with non-essential services starting to resume in some areas. Recent reports are that patients who are concerned about the risks of contracting the virus and those who have suddenly lost their health insurance along with their job may delay preventive or other non-urgent care. This may lead to more intensive or more expensive care needs in the future, and that is a concern. The economic news is not all bad, though. Online retailers, services that can be provided remotely, and raw materials that households can use to become more self-sufficient are doing relatively well, and those industries should continue to thrive. Other hard-hit parts of the economy, like retail stores, travel, and transportation companies, may take longer to recover, but they are adjusting to address these new norms as well. As scenario for future waves of the pandemic become clearer, the likely paths and timelines for economic recovery across different industries will be identified and laid out by economists. However, recognizing the strong connection between the pandemic and larger economy, it seems likely that most business models will adapt to reflect the public health recommendations that are needed to protect workers and consumers alike. Over the long run, the economic shocks and other changes that resulted from the pandemic will be built into business plans, perhaps with more contingency planning for remote work and remote education to provide needed flexibility for households. This planning will be very important as future waves of the pandemic unfold. Part of what makes predictions challenging is the nature of this virus. COVID-19 cases have a prolonged lag of up to 14 days between infection and when the symptoms appear. Many people do not even know that they are infected. This delay means that it may seem like the reported number of cases increases while people are staying at home, and that the number of cases decrease when more social interactions are allowed. The delayed health consequences, diagnosis, and reporting once a person is exposed may lead to a pattern where the cases and deaths seem to be increasing while more restrictions are in place and then decreasing when there are fewer restrictions in place. And that can lead to a misperception that public health precautions are not working and may even lead to more spreading of the disease. The bottom line is that until we have a vaccine and a uniform containment plan, the future waves of COVID-19 and its effects on our health and economy will remain fairly uncertain.
In closing, I would like to thank my 5 colleagues from our School of Public Health for taking their time to share their expertise and experiences with us today. I hope you have found this program to be informative. Thank you too for participating, and gig 'em.